Yeah, that's why I'm just trying to make a space for myself. All right. I'm pleasantly surprised that I'm promoted to speak earlier than my scheduled time. We'll talk very briefly about immune modulation for ocular surface disease, topical as well as systemic. This is a patient I managed very early on who has undergone pterygium surgery in 2000, and he had no allergies. His vision was 20/100 in the right eye and 21/25 in the left eye. And you look at the video. This is a extensive necrosis of the sclera at the site of surgery, and there are some other metastatic lesions also. It's typical case of a surgically induced necrotizing scleritis. Such patient, you need to, after doing initial investigation and ruling out any other underlying immune mediated diseases, you need to treat with systemic treatment along with the topical. So what you are seeing here is after he received 6 weeks of intense immunomodulation, you can see the hooking of the medial rectus muscle, and then seeing if this necrosis is going beyond the insertion of the muscle, and then making a space for suturing your scleral patch graft, and then we will reattach the muscle there. So I'll skip this, and then you see this patient received IV methylprednisolone, cytoxin, that is cyclophosphamide, topical and systemic steroids, and this continued for 9 to 12 months. Post, and he had a continuous monitoring, and post follow up about 1.5 years, the graft is well taken. He has developed cataract, which was phaco was done, and he developed very good vision of 20/25 in that eye. This is another gentleman who presented with the acute onset of redness of both the eyes, and he had these mouth lesions also. So initially we thought it's some sort of conjunctivitis, or during the winter season, but he had a history of fever, some and taking of antibiotics. His skin biopsy was negative for pemphigus, and he over a period of time his conditions became little better, but not a lot. And then we thought that it's probably EM minor or a Steven Johnson syndrome. He received topical and systemic steroids. This is 2 months later, and this is at this stage it looked like that it may not be SJS and maybe ocular pemphigoid. So we started treating along those lines and did a conjunctival biopsy. So he then was very well controlled on systemic methotrexate along with low dose typical topical systemic steroids, and also received a pulse dose of cyclophosphamide. He has been using the Pros lens and is doing very well. OCP, as you know, is a very systemically driven immune mediated organ specific disease in the eye, in the conjunctiva basically, and the proper way of diagnosing this condition is taking the conjunctival biopsy and then doing subjecting it to immunohistochemistry in the lab. So you can see these are the this is what we are looking at, apple green this staining here and this area, and this is how you take the sample and you snap freeze in liquid nitrogen. We have been talking about ocular surface since morning. This is not just the conjunctiva, it is also there is a huge amount of immune system which is associated with it. It's called conjunctiva associated lymphoid tissue or eye associated lymphoid tissue. All of these contribute to the immune response because this ocular surface is exposed to the environment continuously, and there are variety of secretory immunoglobulins, cytokines. Among the topical immunomodulation, the cyclosporin A has been in use for over 25-30 years now, and it is quite effective in certain conditions. Others are tacrolimus, which I use for mostly for VKC associated inflammation, and sirolimus. We did a clinical trial for uveitis treatment, but not for ocular surface treatment. Liftigrast, Rohit talked about it in his talk, and essentially it works on a very different mechanism on is adhesion molecules essentially. For example, in patient with moderate or severe VKC, like this picture shown here, in these kind of eyes, topical treatment alone would not be sufficient. So I use systemic steroids and also systemic immune modulation for these patients. And this is the kind of algorithm that I follow, that they would use topical and systemic immunomodulation. Not only steroids, I will use cyclosporin also. And if there is a need, I will use supratarsal steroid injection. And if there is a sealed ulcer, treat it with the amniotic membrane. And for systemic steroids, these are the indications for me in patients with VKC, moderate to severe VKC, persistent symptoms, thick mucus discharge, and persistent limbal inflammation. The reason we need to use immunomodulation for ocular surface disease is, despite having a good range of treatment, there is almost 1/3 of these patients go blind because of inadequate treatment. Conditions like OCP, necrotizing scleritis, PUK, Wagner's granulomatosis, all they need systemic treatment. The topical treatment is ineffective in this condition. And like if you have necrotizing scleritis with rheumatoid arthritis, if you don't treat with systemic immunomodulation, the mortality is very high, and that is because of the vasculitis of the visceral organs. And these are the indications for immune modulation for ocular surface disease, like KCS with Sjogren syndrome, ocular sickest, OCP, AKC and VKC, necrotizing scleritis, and of course for high-risk grafts, limbal allografts. The main philosophy here is that we want to control the symptoms, we want to preserve or restore the patient's vision, and also save the life. It will, the kind of treatment will be dictated by degree and location of inflammation, visual assessment whether the damage is reversible or not, and there are some indications like allograft, OCP. Here you don't really have a choice that other than you treating them systemically along with topical. These are some of the groups of medicines that we use. I am trained in using these medicines as a fellowship in ocular immunology with Dr. Foster long back. But those of you who are scared or don't have familiarity, maybe collaborate with the rheumatologist or hemato-oncologist, and you take part of the care of the eye part, and they manage medicines. The reason the corticosteroid, the most effective immunosuppressants, are because of their mechanism of action. They dramatically inhibit the transcription factors of inflammatory cytokines, and also they do the activation for inflammatory proteins, and associated with that are their side effects. And some of these side effects, which are almost universal, is the weight gain, the mood changes, and if there is a child is less than 15 years, there may be a growth retardation. So it's very important that we monitor the side effects. These are some of the other side effects for long use. These are rare side effects, but they do happen. But so if you start systemic medications, either you take the responsibility of monitoring or you collaborate with someone. These are the indications specifically we talked about, mainly immune modulation for immune mediated diseases, and if they are steroid dependent inflammation. Usual doses of starting, I have been using all these 4-5 medications for last 25-30 years. This is standard screening you do, and periodically every 2 to 3 months. If it is cyclophosphamide, you repeat the test every 3 to 4 weeks. Biologics, I don't use myself, but I have physicians who I work with, those patients who need, and they are very effective in certain indications. So it's very important now, and they are widely available in India at least. And these are different doses. So the therapeutic approach to ocular inflammation would be that we want to achieve remission quickly, and that is best. It's achieved by pulsed immunosuppression. Pulse means that you give IV methylprednisolone and or IV cyclophosphamide as a pulse therapy every 2 to 4 weeks with monitoring of CBC, LFT, and other parameters. You may need to use at least 2 medications. Like I use systemic steroid along with immunomodulation if I think that steroid alone will not be sufficient, and regular and careful monitoring of for side effects. So in summary, steroid still remains the mainstay in the acute phase of immune-mediated inflammation of the surface. For deeper inflammations like Wagner's and rheumatoid arthritis, you should think of immune modulation as a steroid-sparing strategy. If you use steroids for long term, the side effects become unacceptable. So immune modulation is something that we all, or most of you who are interested in managing these kind of diseases, is important to learn, and that in fact is a standard of care. Thank you very much.